Hello again. Welcome to Lesson 2, Part A. In this lesson, we have several slides with certification-type questions to spark your thinking and help guide your independent study. After viewing this slide set, be sure to open the answer key slide set to check on your answers after having researched the questions. This is the first of two lessons that have to do with treating infections, and our objectives are listed here. We analyze the phenomenon of antibiotic resistance, particularly in this lesson, and we apply concepts of microbiology to the choice of antibiotic therapy. In Part B, you will actually walk through a case and go through clinical decision-making on a specific problem. And today we're going to focus on the pediatric population versus the elder population, which we had talked about in our first lesson. So how do antibiotics work? In this case, we're going to focus on the beta-lactam antibiotics. So one of the things I want to kind of introduce you to is, as you study and think about all of the components of your lessons each week, don't be afraid to jump out onto the internet and take a look at some things. So let's go ahead and Google her up and look on the mechanism of action of the beta-lactams. So I'm just going to go ahead and start typing, and of course I had already looked this up, so I found a great website, which is actually a veterinarian website, that gives us some great information. So it tells us that the mode of action is inhibition of cell wall synthesis, and that makes lots of sense because when you think about bacteria who are single-celled organisms, they rely upon, many of them at least, rely upon the cell wall to function. In some cases that's not true, but in most of the bacterium we're talking about, that is true. So you look here and see that it's basically the beta-lactam antibiotics target the penicillin-binding proteins, or PBPs, which are enzymes found in the cell membrane. And of course, then, if those are broken down, the cell will die because of osmotic instability or autolysis. Switching gears a little bit and thinking about why things become resistant, or various bacteria become resistant, I will ask you to refresh your memory by reading or by viewing the TED Ed YouTube on antibiotic resistance. It's an excellent brief overview that kind of gives you the sense of what's going on with antibiotic resistance. There are many mechanisms for antibiotic resistance, and the two excellent articles by Oliphant that I gave you in your readings will guide you through a lot more detail. Now, there are predictions, as noted in the TED Ed YouTube, that we are really going to see a post-antibiotic era. So now we talk about DROs, drug-resistant organisms, and those are fairly commonplace even in the community. Originally, these were problems in a hospital setting. MRSA, the one we kind of know and love to hate, is the first one we kind of heard of several years ago. Again, sparking back to my own history in nursing, I clearly remember the day when there was no such thing as a drug-resistant organism. There was no MRSA. There were no organisms that we couldn't fight one way or the other. So the question is kind of, what do we do at this point? Things are tough. This is a cute little cartoon. This guy, little fellow, saying, "Hey kid, want to be a superbug? Stick some of this into your genome. Even penicillin won't be able to harm you." And it says in the caption, it was on a shortcut through the hospital kitchens that Albert was first approached by a member of the antibiotic resistance. Okay, so a couple of certification questions that you might want to go and research. And this refers to the mechanism of resistance of DRSP. Now, what is DRSP? Well, this is short term for drug-resistant strep pneumoniae, and in a few minutes you're going to understand why this is so very important in our pediatric population as well as adults. Strep pneumoniae being one of the respiratory gram-positive organisms that causes a lot of trouble for us. So there are choices here. I'm not going to give you the answer. You can see it later on. But you'll see in the next question, this can be confusing because the same four answers are given about what's going on in terms of Haemophilus influenzae. And this particular germ, it is not influenza that we think of, the influenza virus. This is Haemophilus influenza, which is a bacterium, which causes also is one of the causative organisms that we see in respiratory illnesses. Another cartoon, just for a little laugh break. The provider says it's a prescription for one of those new super antibiotics. You won't just get better, you'll get even. So that's talking about super antibiotics. But what about super infection or secondary infections? And sometimes these terms are used interchangeably. When we think of day-to-day problems that emerge from antibiotic use, we have some fairly common secondary infections which occur when the antibiotic basically wipes out some of the microbes in the body that are helpful microbes and give us troubles. So a fairly common one that you probably are familiar with, may have even had happen to you if you're female particularly, might be a yeast infection or candida overgrowth in the vaginal tract secondary to antibiotic use. The big question, of course, is what can you do? We'll get to this shortly in terms of being a very careful steward of antibiotic use, but in the event that you need to provide antibiotic therapy, certainly treating the secondary infection is something that we also take care of. And I will tell you that many of us in practice routinely prescribe a one-day course of diflucan, which is an antifungal medication, which is taken orally, which can fight away the vaginal infection, which can come secondary to an antibiotic when we prescribe the antibiotic. Seems like craziness, but sometimes that's the smartest thing to do. Saves the patient a lot of hassle and phone calling. Now, less commonly, there may be some kinds of superinfection or serious secondary infection going on. I think particularly, and many of you are familiar with hearing either in the media or in work that you have been around patient care in hospitals, and think of something like Clostridium difficile or C. diff or C. difficile, which is a bacterium overgrowth that can cause a severe form of diarrhea and be very dangerous for certain populations. The same kind of answers in terms of prevention prevail here, but in fact, we do have treatments for Clostridium difficile. We do have other antimicrobials that are used to treat that. But again, they of course bring on their own problems, and we even now have novel treatments such as fecal implants, which sounds crazy, but it's true. We take healthy fecal materials from healthy subjects and implant it or transplant it into the colon of the person who has been struck with C. diff. So we have key principles in terms of our stewardship of antibiotic treatment. First of all, we want to really narrow the spectrum of the drug we're going to use. We want to know the pathogen or usual suspect for our empiric therapy. And empiric therapy is an important concept to understand, especially in primary care. We rarely take a culture of a particular organism or infection and try to decide how to treat a patient by the results of a culture and sensitivity laboratory test in the community. We do that in the hospital. We often start treatment, however, empirically or without really knowing exactly what we are treating. And we do that based on past experience, past research that has told us what the usual suspects are going to be for this particular infection. So we try to narrow the spectrum. And you'll notice when you look up the particular drugs that are involved in the antibiotic choices, that some of them will be considered very narrow spectrum. In this case, let's talk about penicillin versus amoxicillin, because those are both beta-lactam drugs. And penicillin is very narrow in its spectrum of activity. It only targets a few different microbes. And we'll talk a little bit more about how you can figure this out later by looking in your Sanford guide to figure this out. And then something like amoxicillin is a broader spectrum drug, and it hits many bacterium. The rationale for using the narrow one is that we just want to target the particular organism that we're trying to kill. Of course, if we have multiple organisms in our list, we might have to go broader spectrum. We go with the shortest course necessary, and you will see if you look up drug treatment protocols from even 5 years ago, 10 years ago, and clinical guidelines, that you will see that the courses of antibiotic therapy were longer at that time. You'll see recommendations for 10 days, 21 days, 7 days in certain things. And nowadays you'll see them as short as possible, 3 days, 5 days, 7 days, something like that. We use higher doses for this shorter course of therapy to try to knock out the bacterium as quickly as possible. And of course, avoidance is our first strategy. There is such a thing called an antibiogram, and these are only available, of course, for organisms or infections for which we have actually done a culture and sensitivity. These are done by hospital labs. You will not find this in a community setting per se, but you will want to contact your lab that services the local hospitals to get something like this. This is especially helpful in the case of urinary tract infections, where you have, we do have cultures and sensitivities that are done. And you'll see by looking at this table that particularly the top gram-negative organism is, I can't even say it, E. coli is the way we talk about it. And what antibiotics it has the most sensitivity to. And we find that in this case, on this particular antibiogram, and they are very community specific, about 81% of the E. coli are going to respond to the trimethoprim sulfamethoxazole, which is Bactrim, and 95% are going to respond to nitrofurantoin, which is another antibiotic used for urinary tract infections. So although providers may say, oh, I always use Bactrim, or even ciprofloxacin, which is very commonly used and not necessary for a minor infection, you'll see that it has a very low amount of susceptibility in this particular population, probably because it's been overused. So you use this to guide you because it will change over time, and in certain communities, that situation will reverse. Now, when we get into children, we have to think about some specific things, and this will apply to our case that we're going to do in Part B. Kids are special. They actually need more drug per body mass than adults. However, we do maximize the dosing for children at the adult dosing level. So here's some questions to ponder. We do use a mathematical formula. We have to, of course, convert pounds to kilograms, if not already done so, when we weigh the patient. The doses are always given in either milligrams per kilogram or milligrams per body surface area, and so this all has to be calculated ahead. We have to know how many doses per day, and this depends upon the recommendations that we read in our resources. And then we have to look at how it's supplied and decide how many milligrams per dose we're giving. It's fairly complicated. Hippocrates has a wonderful app that helps you with it. Do be careful because some drugs are given, for example, in milligrams per kilogram per day in 3 divided doses, which is different than milligrams per kilogram per dose 3 times daily. So think that one through. So our antibiotic punch list. We want to decide which microbe we're treating, what's the best evidence-based therapy, how long to treat, and which drug we're going to use. This is the end of Part A. Please tune in to Part B.